अस्सलाम वालेकुम बेटा, आवाज आ रही है? म्यूट करो कमान। मैंने पूछा बेटा आवाज आ रही है? अस्सलाम वालेकुम। अस्सलाम वालेकुम। बस म्यूट करे चले ना। अस्सलाम वालेकुम बेटा। Today's topic is carcinoma of the breast, different carcinomas. Last हमारा जो topic था inflammatory conditions थी। Bismillahirrahmanirrahim. Epidemiology. Breast cancer, it is the most commonly diagnosed cancer among the women with investigated 260,000 newly diagnosed women with invasive disease, accounting for approximately 15 to 30% of the all new cancer cases among women. In men in 2019, the estimate is more than 2,500 new cases of breast cancer and accounting for less than 1% of all new cancer cases among men. Each year, nearly 42,000 women die of breast cancer, making it the second leading cause of cancer deaths among US women after the lung cancers. The lifetime risk of dying of breast cancer is approximately 2.6%. Okay. The international incidence of female breast cancer varies, markedly being highest in the United States and Northern Europe, intermediate in South and East part of Europe and South America, and lowest in Asia. However, the incidence rates have been rising traditionally in low incidence Asian countries, particularly Japan, Singapore, and urban areas of China, and the reason is the transition toward a Western style economy and pattern of reproductive behavior. The risk factors the gender. 1% cases occurs in male and 99% occurs in females. Age. Breast cancer incidence rates increase sharply with advancing age and peaks at 75 to 80 years of age, then declining slightly thereafter. The carcinoma is uncommon in younger age group. The age at menarche and menopause. Earlier age at menarche has been consistently associated with increased risk of both premenopausal and postmenopausal breast cancer. The late age at menopause increases the risk of breast cancer. After menopause, the adipose tissue is the major source of estrogen, and obese postmenopausal women have both higher level of endogenous estrogen and higher risk of breast cancer. Another factor is age at first live birth. Risk will be half than a nulliparous woman to a woman who experiences a full-term pregnancy at the age of 20 years or younger. First-degree relatives with breast cancer. It is another risk factor. The risk increases with the first-degree affected members, mother, sister, or daughter. The mutations in the BRCA1 and BRCA2 genes markedly increases the risk of breast cancer. Atypical hyperplasia. It increases the risk of invasive cancer. Estrogen exposure. Postmenopausal hormone replacement therapy. increases risk of breast cancer, and the women who have undergone bilateral oophorectomy at the young age have a greatly reduced risk of breast cancer. Women with bilateral oophorectomy before the age of 45 years have approximately half the risk of breast cancer compared to those with a natural menopause at the age of 55 years or older. Another risk factor is high breast density on mammogram. High breast radiodensity is a strong risk factor, and detection of cancer is more difficult in the presence of density. Radiation exposure. Previous radiation exposure increase the rate of breast cancer. Carcinoma of the contralateral side or endometrium. 1% women with breast cancer develop carcinoma on contralateral side, and risk is higher for the women with germline mutation in BRCA1 and 2 genes, and the prolonged estrogen stimuli is common risk factor for breast and endometrial carcinoma. The risk factors you can control here are: number one, weight. Being overweight is associated with increased risk, especially women after menopause. Diet, alcohol consumption, again a risk factor. Breastfeeding, the longer women feed, the greater reduction in the risk of developing the carcinoma breast. Tobacco, we all know tobacco is a very strong risk factor for carcinoma. Environmental toxics, organochlorine pesticide, it has a potential to produce the cancer. Classification of the breast cancer, the carcinoma in situ, total 15 to 30% of the cases are carcinoma in situ. And the carcinoma in situ are either ductal carcinoma or lobular carcinoma. The ductal carcinoma in situ is 80% of the total cases, and the types of ductal carcinoma in situ are comedocarcinoma, solid, cribriform, papillary, and micropapillary. These all are types of ductal carcinoma in situ. The lobular carcinoma is only 20%. Now, invasive carcinoma. These are 70 to 85% of the total cancer cases. Invasive carcinoma, no special type, NST or invasive ductal carcinoma. Invasive carcinoma, no special type, or invasive ductal carcinoma, total 79% of the cases. Invasive lobular carcinoma comprises only 10%, tubular or cribriform 6%, mucinous or colloid carcinoma 2%, medullary 2%, invasive papillary 1%, and metaplastic less than 1%. Carcinoma in situ. What is carcinoma in situ? It is a neoplastic proliferation that is limited to the duct and lobules by the basement membrane. DCIS or ductal carcinoma in situ consists of malignant clonal population of cells limited to the ducts and lobules by the basement membrane. Myoepithelial cells are preserved or decreased in the number. It can spread throughout the ducts and lobules and will produce extensive heme. In case of lobular involvement, the acini are usually distorted and unfolded. Types of ductal carcinoma in situ. Number one, comedocarcinoma. It is characterized by presence of solid sheets of pleomorphic cells with high-grade hyperchromasia. Nuclear hyperchromasia. Central necrotic area. Necrotic cell membrane become calcified. Periductal concentric fibrosis and chronic inflammation is commonly seen in comedocarcinoma. Clinically, lesion is characterized by palpable nodular mass and hemorrhagic nipple discharge. DCI is usually detected on mammogram. Calcification of the periductal fibrosis is usually seen on mammogram, cribriform DCIS or clone tomato DCIS. Cookie cutter line. You can see this cribriform pattern. This cribriform showing penetrations, human bridges, and reticular bars. In the cribriform DCIS, the round fenestration are found within the glands. The more regular these spaces in the size and shape and distribution, the more likely gland to be malignant. These blackish areas, this is microscopic, ultra microscopic, or high power view. Not ultra microscopic, but on the high power view. These are the blackish areas. These are the microcalcification in the DCIS. Second form is DCIS solid. Here the lesion fills the whole space. Another form DCIS papillary. Papillary DCIS grows into the spaces along with fibrovascular pores, lacking the myoepithelial layer. DCIS micropapillary form. It is characterized by bulbous protrusion without fibrovascular pore, arranged in complex pattern, often intraductal pattern, complex intraductal. This one is the micropapillary pattern. You can see the micropapilla without fibrovascular pore. This variant of the DCIS showing slender elongated epithelial fronds projected within the glandular lumen or inside the glandular lumen. These projections are solid and laid through fibrovascular core. They are composed of uniform population of tumor cells with intermediate nuclear grade. Some of the papillary fronds projecting into the lumen may cut transversely. These one. Some of papillary fronds projecting into the lumen may be cut transversely and resulting in the appearance of small detached irregular clusters of tumor cells. These are later in the lumen. These are nothing but these are the cut sections of these papillary fronds. Lobular carcinoma in situ. It is usually an incidental finding most commonly seen in the upper outer and inner quadrants. It is multicentric in about 70% of the cases and bilateral in 30 to 40% of cases. The lobules here are expanded, completely filled by uniform population of round, small to medium-sized tumor cells. Atypia, nuclear pleomorphism, mitotic activity, and necrosis are usually absent. Scattered signet ring cells are frequently present. The tumor cells may show Paget spread into the neighboring terminal layers. However, Paget disease is almost never seen. This one is a microscopic picture of the lobular carcinoma in situ, a non-palpable lesion, usual incidental finding in the breast, removed for other reasons. Multicentric, it is multicentric in 70% of cases and bilaterality in 30 to 40% of cases. Lobules here are distended with uniform round to oval medium-sized cells. Nuclei are uniform, normochromatic. Several lobules are involved here. The diagnosis should be applied in those cases where cellular proliferation results in formation of solid discs. You can see here that expand the entire lobule. Invasive carcinoma breast. Almost always present at less palpable mass, and 50% of the mass are associated with axillary lymph node metastasis at the time of diagnosis. Larger carcinoma causing dimpling of the skin or fixation with chest wall, retraction of the nipple resulting from involvement of central portion of breast. These are clinical features of the breast carcinoma. Invasive breast carcinoma clinical presentation. Beauty orange, the skin of an orange peel appearance. It is due to the dermal edema caused by obstruction of the superficial cutaneous lymphatics by the tumor. The infiltrated skin is tethered by the sweat ducts such that it cannot swell, leading to dimpled appearance. This one, you can see the clinical picture of the carcinoma of the breast. Larger carcinoma causing dimpling of skin, fixation with the chest wall, retraction of nipple resulting from involvement of central portion of the breast, beauty orange appearance due to the obstruction of the cutaneous lymphatic by tumors. This one is inflammatory carcinoma, swelling erythematous mass caused by extensive invasion and obstruction of dermal lymphatics is termed as inflammatory carcinoma. It is accompanied by diffuse edema, beauty orange appearance involving a third or more of the skin overlying the breast, and the skin changes are due to edema caused by widespread tumor emboli within the dermal lymphatics. Bilaterality in breast cancer, approximately 4% of the women with newly diagnosed breast cancer are found to have contralateral breast. Patients with bilateral carcinoma have a greater frequency of multicentricity in one or both breasts as compared to the women with unilateral carcinoma. Gross pathology, invasive ductal carcinoma usually form a solid mass with a variable consistency. Consistency is variable, not a single consistency. Tumors with abundant desmoplasia are firm to hard gray white in appearance. And the presence of microcalcification in the tumor may impart a gritty consistency feel on cutting, gross cutting. There may be necrosis and foci of hemorrhage. Tumors that are largely composed of neoplastic and inflammatory cells without much stroma, they are tend to be fleshy and bulges when they are sectioned. Tumors have an irregular or stellate outline with indistinct configuration with well circumscribed contours or an admixture of both two patterns. Stellate tumors often show gray-white strands of surrounding fat. Grossly circumscribed tumors may still show pattern. Microscopically. Microscopic finding in well-differentiated tumor. There is prominent tubule formation, small round nuclei. Mitotic figure is rare. Moderately differentiated tumors may have tubules, solid clusters, or single infiltrating cells are also seen. There is greater degree of nuclear pleomorphism. Mitotic figure is present in moderately differentiated tumor. The third form is poorly differentiated carcinoma. Raised nests or solid sheets of cells with enlarged irregular nuclei. Proliferation rate is higher as compared to well-differentiated or moderately differentiated. Necrosis is common here. This one is a gross picture of invasive ductal carcinoma. Usually form a solid mass with a variable consistency. I have told you earlier, tumors with abundant stroma, desmoplastic stroma, are filmed to hard gray white in color. Presence of microcalcification within the tumor may impart gritty consistency. There may be yellow-white streaks of necrosis and foci of hemorrhage are present. Other tumors are soft and fleshy and bulges when they are sectional. Another gross picture of invasive ductal carcinoma. Tumor can have irregular or stellate outlines with indistinct borders. Okay. Stellate tumors often show gray white streaks of tissues. You can see here radiating into the surrounding tissues or bed. Microscopic picture. Tubules or duct formation is a marker of degree of glandular differentiation in ductal carcinoma. Only with clear-cut central lumen is counted here. Modified Scarf-Blue-Richardson grading system is based on the degree of tubule or duct, nuclear grade, and mitotic. Gene expression pattern in the no special type or invasive carcinoma, invasive ductal carcinoma. In luminal A type, slow growing tumors, ER positive, ER estrogen, and HER neonegative. These are receptors. 40 to 55% of the tumors. Luminal B, ER positive, HER neopositive. 15 to 20% of tumors. Normal breast like ER positive, HER neonatal. These are 6 to 10% of the total, no special type or invasive ductal carcinoma. Basal like, there is absence of ER, PR, ER for estrogen, PR for progesterone, HER2 neoreceptors, but presence of myoepithelial cell markers. These are 13 to 25% of the total cancers. HER2 positive. In this group, tumors included are ER negative and those overexpress the HER2 receptors. This is a pattern of invasive ductal carcinoma. Now the invasive lobular carcinoma. Invasive lobular carcinoma, it makes up about the 10% of all invasive breast cancers. It tends to occur a little later in the life than invasive ductal cancer. HRT or hormone replacement therapy after menopause increases the risk of ILC. The size of lobular carcinoma, invasive lobular carcinoma, ranges from grossly inapparent gland that may diffusely involve the breast to discrete film gray white mass with irregular borders. Frequently, it creates an ill-defined thickening or fullness in a portion of breast which feels different than the surrounding tissues. It is also difficult to detect on mammograms, but MRI is superior to ultrasound in mammography in visualizing the tumor. Most of the ILC are ER positive. ER, estrogen receptor positive, and the metastasis occurs in the peritoneum, retroperitoneum, leptomeninges, gastrointestinal tract, ovaries, and uterus. This one is a microscopic picture of the ILC. Microscopically, it consists of uniform population of cells, small to medium-sized tumor cells that exhibit the lack of cohesion. In a classical case of ILC, they grow in a slender or strands or single files, or in a concentric fashion around the ducts or lobules harboring the lobular carcinoma. The background stroma is densely fibrotic. You can see the pinkish stroma, thick stroma. A lymphocytic infiltrate is frequently present. This one is a classic picture, microscopic picture of the tubular carcinoma. You can see the strands or single files of the cells. These are Indian files. These are termed as single strands of the multiple cells. It is characterized by uniform population, small to medium-sized tumor cells. The cells grow in cylinder, strands, or single files. This is termed as Indian file. The background stroma is usually densely fibroid. Another variant of invasive carcinoma is the tubular carcinoma. Tubular carcinoma, distinct subtype of invasive ductal carcinoma. It is composed of simple but neoplastic angulated tubules. The angulation you can notice every tubule. See the angulation. Okay. Composed of simple neoplastic angulated tubules, it makes up less than 2% of the all breast cancer, and the tumor size is less than 1 centimeter in more than 95% of the cases. Most cases are non-palpable and almost always detected on scanning mammography. There is high incidence of multicentricity and bilaterality and family history associated with tubular carcinoma. Low power microscopic view of tubular carcinoma. These tend to be stellate or irregular lesions with infiltrating borders, irregular proliferation of small glands and tubules, C-layer glands and tubules lined by single layer of cuboidal or columnar epithelium and have angulated contours, widely open lumen. Absence of bioepithelial cell layer, bioepithelial cell layer. Tubules are separated by abundant stroma. Stroma is more in between the tubules or glands, containing myofibroblast. Stroma containing myofibroblast, elastic tissue, and myxoid matrix. Calcification also present here. Mucinous or colloid carcinoma. Pure mucinous or colloid carcinoma, it makes up about 2% of all breast cancers and occurs in older women. The median age is 71 years. The term mucinous carcinoma is restricted to the tumors showing stromal mucin in more than 90% of the tumor and exclude tumors containing areas of ordinary invasive ductal carcinoma and signet ring cell carcinoma. Patients are usually postmenopausal and the tumors are well circumscribed, have a gelatinous bluish gray cut surface. Microscopically, the mucinous tumors are well differentiated tumor cells arranged in solid nests. Trabecular formation, cribriform clusters or papillary structures are seen floating in the pool of copious extracellular mucin. This one is a gross picture of the mucinous or colloid carcinoma. On cut section, you can notice a gelatinous, gel-like bluish gray surface of a mass within the normal tissue. This one is the microscopic view. The diagnostic hallmark of the mucinous carcinoma of breast is the clusters of invasive tumor cells in the pool of abundant extracellular mucin. Mucin pools are partially separated by delicate fibrous septa. Notice here, tumor cells are arranged in solid cribriform and trabecular pattern. Medullary carcinoma. Medullary carcinoma is more common in 6th decade of life. It will present as rapidly growing mass. Clinically, as well as on radiological examination, it mimics with benign lesions. Grossly, it is a well circumscribed mass, soft and fleshy in consistency. Microscopic features of medullary carcinoma: the solid syncytium-like sheets of large cells with vesicular pleomorphic nuclei and prominent nuclei, which compose more than 70% of the tumor mass. Mitotic figure is very frequent and moderate to marked lymphoplasma site infiltrate surrounding and within the tumor and pushing borders. Invasive papillary carcinoma, it makes up about 1%, 1 to 2% of the breast carcinoma in women, and the patients are usually older than with other breast carcinomas. These are more commonly seen in DCIS. Invasive papillary carcinomas are usually ER positive. High power view of invasive papillary carcinoma. Uniform population of the glandular cells. See, these are the uniform population, uniform sized. These invasive papillary projections show papillary carcinoma show several capillary structures with fibrovascular pores inside. Features favoring carcinoma are the uniformity in the size and shape of epithelial cells, lack of myoepithelial cells, nuclear hyperchromasia, nuclear enlargement, you can see here, and mitotic rate is high. These features are favoring the carcinoma, diagnosis of carcinoma. Metaplastic carcinoma. In metaplastic carcinoma, predominant type of cell is usually mesenchymal element. And the total of metaplastic carcinoma make up less than 1% of all mammary carcinoma. Most common metaplastic elements here are spindle cells, then squamous cells, and other elements included are chondroid, osseous, and sarcomas. Epithelial component is usually DCIS or invasive ductal carcinoma, rarely nodular carcinoma in situ or atypical ductal hyperplasia may seen. Chronic inflammation within and around the tumor is a frequent finding here. Morphologic range of metaplastic carcinoma are spindle cell carcinoma, sarcomatoid carcinoma, chondrocarcinoma, osteocarcinoma, matrix-producing tumors, matrix-producing carcinomas, metaplastic high-grade atenosquamous carcinoma, carcinoma with osteoclast like giant cells, and metaplastic carcinoma with choriocarcinoma. ER, PR, HER2 triple negative tumors. Paget's disease. Paget's disease of nipple and areola is a rare form of intraepidermal adenocarcinoma that is almost always associated with in situ or invasive breast cancer. It appears as an eczematous, scaling pleuritic eruption of the skin, clinically mimics the inflammatory dermatosis. It arises by intraepidermal migration of ductal carcinoma cells through the lactiferous ducts to the surface epithelium of the nipple and areola. The rare cases not associated with breast carcinoma are thought to be arises from the epidermal trocar cells. Paget cells infiltrate the entire thickness of epidermis singly or in mass. In the form of mass, they have voluminous, clear or pale eosinophilic cytoplasm, vesicular nuclei, prominent nucleoli, increased mitotic activity, glandular and acinar structure, signet ring cells within with intracytoplasmic with intracytoplasmic may present. This one is a gross picture of Paget's disease, scaly, thrusting, ulcerating lesion, total destruction of the nipple. Lesion itself is indurated. Clinical features generally seen in females in their 5th or 6th decade of life. Unilateral in most cases, a palpable breast mass is also present in most cases. Usual presentation of breast is with red, pink, pleuritic lesion of nipple or areola or complex. As the disease progresses, there is bleeding, ulceration, and bloody or discharge from the nipple. The nipple can become deformed or inverted and may be completely destroyed in advanced cases. tumor nodules can appear in later life. The microscopic feature of Paget's disease or memory Paget disease that involved skin show acanthosis, hyperkeratosis, thickening. There may be erosion or ulceration seen, infiltrating the entire thickness of large pleomorphic malignant cells scattered either single or in the form of buckshot pattern. Arranged nests or as solid sheets, tumor cells may extend into the adenosine structures. The Paget cells have voluminous, clear, eosinophilic or foamy cytoplasm. You can see the single cell, voluminous cytoplasm, pale, eosinophilic. The mitotic activity is increased here. Large size cells, pale cytoplasm. You can notice here a clear picture. Mitotic activity. Thank you so much.